So, okay, welcome everybody. Thank you for joining us on this, the first ITP Nurses forum meeting that we've actually held during ITP Awareness Week. In the UK and around the world, today is the first day of ITP Awareness Week. There's loads of events taking place in America, all in South America, all over Europe and the UK. I'd like to thank you all for registering and taking part in tonight's meeting. I'm pleased to introduce to you someone many of you will probably know or should know. If you don't, you're in trouble. Miss Louise Taylor, ITP nurse consultant from the Royal London Hospital in London. Louise will be talking on various subjects around ITP, you know, what to look out for with ITP, and you know, what new nurses should actually also look out for. I'm just going to give a quick overview of some of the work of the ITP Support Association right at the very start of this meeting, just to give you a flavour of what we got and what resources are actually available for everyone. Please be aware that we are recording this meeting, and the reason we're recording this meeting is probably because over 60 people registered, but some of them knew that they wouldn't be able to make it. But so they've asked if it can be put on our YouTube channel tomorrow. So that's what we aim to do. Okay, I'm going to just quickly share my screen. Okay, as I said, my name's Mervyn Morgan. I'm from the UK and Ireland ITP Support Association. These are my disclosures, only a few. The main things I want to talk about today are some of the resources we've got, and many of you would probably have seen copies of this around your hospital, in your haematology units, etc. 2 years ago, no, 3 years ago now, we did a patient perception survey, and out of that came a project that we called the ITP Roundtable Project, where we got a number of clinicians, ITP nurses and patients around the table to work out what the main outcomes from the survey were. And flowing on from that, we produced a booklet, a shared decision-making toolkit for ITP patients called Making the Right Choices in ITP Management and Care. And we were really pleased. We managed to get the Royal College of Pathologists to endorse it, the Royal College of Physicians, Royal College of General Practitioners, the British Society of Haematology, and the Genetic Alliance UK. All of them organisations have endorsed the booklet. To date, we've had, I think it's just over 7,000 digital downloads, and we're now approaching 1,300 hard copies have been sent out to hospitals around the country. If you would like hard copies of this booklet, and that is what it looks like. If you would like hard copies of this booklet, please just put your name and postal address in the chat, and we will get some sent out later this week. The toolkit itself, the structure of the toolkit, is fairly simple, fairly straightforward, and most of it is common sense. Basically, it gives you information about ITP, the characteristics of ITP, the prevalence of ITP around the world, around the UK, how it's diagnosed, and the management of the condition. It also gives the patient an understanding the importance of what shared decision making should be, i.e. making shared decision making between the patient and the clinician. And all of this goes towards helping improving the outcomes for the patient. It also gives us, and it's been endorsed now as best practice in collaborative decision making, i.e. it gives you a step-by-step guide from the first symptoms all the way through diagnosis to treatment. And it also gives the patient further information on treatment options. plus details of other patient resources and additional resources that are available. In addition, it's available, hard copy is available in English. Downloadable copies are available in Spanish, German, Italian, French and Portuguese. And again, they have been really, really successful. We've had loads of downloads for those resources. In addition, we've just launched something today. This is an addendum to the toolkit. And I've just put it on our website today. You can download it from our website. It's a little, sort of questionnaire, a 2-page questionnaire that patients can complete before they go for their appointment with either their GP or their consultant haematologist. And it helps guide them in the direction of what questions, they need to ask the consultant when they have their appointment. This toolkit, this ITP discussion guide, was actually developed in conjunction with Sobi. And I'm pleased to say Sobi have actually supported all of our ITP Awareness Week events this week and resources, so thank you, Sobi. In addition to the addendum, we've also got 2 explainer guides, one for healthcare professionals and one for patients. These actually give the healthcare professionals and the patients a background into, why we put some of these questions into the discussion guide, and helps guide them through completion. Another thing we've got going on, I already mentioned 3 years ago we did a survey. This year we've launched our 2022 ITP survey. We've now had over 260 people actually complete the survey to date. And if you've got any patients, please point them in the direction of the survey, because we are getting some very, very interesting results. Some patients are having trouble actually obtaining TPOs for their treatment, which shouldn't happen. And another thing I just want to just make people aware, as you're every year we have a annual patient convention. The last 3 years it's unfortunately been virtual, but next year it's going to be in person. It's going to be at the Royal College of Pathologists in London on Saturday the 13th of May. Registration of that will be up within the next month, so if people would like to go attend that, please register when it's up. And as I said, it's ITP Awareness Week this week. There is an organisation called the International ITP Alliance. The founding members of that are us in the UK and our colleagues at the PDSA in the USA. As you can see now from all the flags, ITP associations are now basically on every continent of the globe bar Antarctica. So it's really spreading. The word about ITP is really spreading. And that's all I've got to say. I'm now going to hand over to Louise, who will be much more exciting than I am. So please, Louise, go ahead.
As I said, immune thrombocytopenia is an autoimmune disorder, but a hematological autoimmune disorder. The patient's own body produces antibodies that cause platelet destruction and suppression of platelets. The platelets, you well know, are involved in forming blood clots to stop bleeding, and patients are extreme risk of bleeding. Next slide. Has it gone through? Yeah. As I said earlier, that ITP affects both genders of all ages, but it says here it affects more frequently in the elderly. No, during pandemic, it affected everybody. During the pandemic, we got it due to COVID, we got it due to the vaccines, we just got it because no reason. And that's one of the reasons why we have an ITP registry, and we ask patients to take part in the ITP registry so that we can find out what is happening and why ITP happens to people. So 1 in 30,000 adults and 1 in 12,000 children a year are diagnosed with ITP. But the biggest problem is that ITP, patients with ITP have other immune disorders. So, did that click through, Mervyn? Yeah. ITP was described in 1735 by Paul Gottlieb Verhulst. A splenectomy was used successfully in 1916 to treat ITP. We say treat ITP, but they didn't follow the long-term progression of the patient after a splenectomy. What they did was they took the spleen out and the platelets went up, and they said it was successful. Who knows if the patient relapsed a couple of years later, but who knows? We don't know. But ITP was also established as an autoimmune disorder in 1951. As you see with this lovely graph, can you see it? Did it change over? I'm just checking. I'll check every time. If a child, the biggest problem with ITP is if you're under 18, you are more, as a child, it usually lasts for about 3 months, and usually about 100%, 99% of the patients actually recover and they never have ITP again. But it's usually that 1% in the children that can cause a long-term problem. And during the week, there is an ITP pediatric meeting later on this week. If any of you are interested in it, please register for it. As you can see, it affects every age group. Makes no difference. Yes, it depends. They seem to have a bit of more of a increase from the ages of 60 to death, but it doesn't mean anything. ITP classification, this is very important for the new diagnosis and the treatment options. This is where the CCGs are taking this as their Bible to give patients TPOs or not to give patients TPOs. So under 3 months, it is a newly diagnosed patient. 3 to 12 months, it's persistent, and 12 months, it's chronic. Patients with ITP, as we've discussed earlier, have an increased risk of bruising and bleeding. But the patients with platelets below 30 are more at the risk of life-threatening diseases. I mean, bleeding events. But those below 10 is when even I can panic, and I don't panic because I don't go according to platelet counts, I go according to bleeding symptoms. But we will discuss that as we go along. Okay, so we're looking at these platelet counts and bruising and bleeding risk. If your platelets are greater than 50, you should have no symptoms, but I do know a lot of patients that do have bruising above 50. And as we discuss ITP as we go along, you'll find out that we will be discussing fatigue. Fatigue, fatigue, fatigue. A lot of patients need need about platelets above 50 to decrease their fatigue score. So yes, we wouldn't normally treat about 50, but if they are complaining of chronic fatigue, we will give them medication to try and decrease the fatigue, because we try and improve the quality of life of our patients. Between 30 to 50 platelets, we get extreme bruising and with minor trauma. Or the person that walks into the front door and bangs himself on the front door, or, you know, we all get that. When the platelets are between 10 and 30, we get spontaneous petechiae or bruising. Let me see if we've got a picture here. I think I have a, no, we'll go back. When the platelets between 10 to 30, they get spontaneous bruising, petechiae, gum blisters. I'm sure there's a slide with pictures on. I'll show them a bit later. And below 10 is when we get internal bleeding. That is bleeding in the urine, intracranial bleeds, and that's the ones that we worry about. And usually we worry more on the very young patients, or the newly diagnosed patients, or the extremely elderly patients. That's when we worry with platelets below 10. As I said, we worry about the increased age gives us a higher risk of severe or fatal bleeding in ITP. But I have to tell you, I've been doing this for 12 years, and I haven't had a patient die of ITP yet or bleeding in ITP, but there have been historical episodes, and Mervyn will know this, where patients have died of intracranial bleeds that weren't diagnosed very quickly. Okay, so what is the pathophysiology of ITP? As I said, we are trying everything to learn about the pathophysiology of ITP. When I started in ITP, it was thought to be a platelet destruction by the autoantibodies. But then as we found out about TPOs, we realized that it is also a two-pronged attack. It is that there is a platelet destruction by the autoantibodies, but somehow the platelet production is suppressed in the bone marrow. So the megakaryocytes, which is the parent cell, can also be damaged by the platelet or autoantibodies, making them less productive. So we use a two-pronged fold of treating ITPs. So it's also knowing what causes ITP, and is it a platelet destruction, or is it a platelet destruction or production? Oh, there's a lovely print picture over here where you can read it yourself. It's very involved. So the increased platelet destruction goes to the spleen. The spleen, this is why they took the spleen out. Nowadays, we don't take the spleen out. We do an indium labeled scan, which is a nuclear scan, and we see where the platelets are being destroyed. If they're being destroyed in the spleen, then we can consider removing the spleen. But there are other treatments for us to prevent taking out the spleen, because we can give them TPOs, which means that we can improve the production of platelets in the bone marrow. So there's more platelets going around. Maybe the spleen won't destroy all of them. Signs and symptoms of ITP, they are usually very, it goes from patient to patient. There is no reason why anybody got given ITP or no preceding illnesses. My general discussion with the patients when I'm talking to them is, have you had any stress in the family lately? Have you gone through a divorce? Has somebody been diagnosed with cancer? Have you had a viral infection? Have you had gastritis? Have you had anything else? And sometimes they've had a viral infection. Sometimes they haven't. Majority of them have told me it's stress, but none of us can actually prove that this is a reason for ITP. But majority of the patients, apart from the ones that get admitted through A&E, that's incidental. The GP did a blood test for something, for a routine blood test, for a job interview, for a insurance claim or something, and then we get frantic phone calls from the GPs to see the patient, or the patient that has gone to A&E with the TKI or purpura. Let me show you these pictures that I've got here. They've gone to A&E with purpura or hematomas. And I mean, this is, you can have one of them or you can have all of them. The purpuras over there, which is, and the hematomas are just your big bruises. The petechiae are the small dotties all over the place. The conjunctival bleeding in the eyes, you can see the mucosal bleeding. Menorrhagia, generally in young women, it can be quite damaging to the patient. When you're making a diagnosis of ITP, you must realize there is no standard test for ITP. ITP is the diagnosis of exclusion. You do everything to exclude any other diseases. You take a medical history, you do a physical exam, you do a full blood count, and the full blood count will show that everything is normal, excepting for a low platelet and a HB, because sometimes an HB can drop because of that significant bleeding. If there's anything else on that full blood count that is way lower of anything else, let's do another test to find out what it could be. We definitely exclude HIV, hepatitis C, CMV, lupus. We do everything. And we actually look at the patient from the head to the toe. We look at the type of bruising. We look at the type of bleeding. We have a discussion on how long it's happened, everything about it. And every single patient is different. What might be apparent in one patient is different in another patient. So there are lots of secondary causes for ITP. That is lupus, antiphospholipid syndrome, CMV, all of those ones. So we've got to exclude those ones. Those can cause secondary ITP. What we are interested in today is primary ITP, which is ITP, the proper ITP, but we are opening up a secondary ITP registry soon for all the other problems. You can get drug-induced thrombocytopenia. You can get post-infection thrombocytopenia. And if you fix up one of those, then usually the thrombocytopenia improves. Deciding when to treat, as I said, greater than 50, platelet count greater than 50, no treatment unless you know the patient very well and you've been treating them for a while and then fatigue is not getting better, then you can treat them a little bit. But that is what I said, individualized treatment. At 30 to 50, we give no treatment unless there is, unless the patient is at risk of bleeding, and then you give prednisolone. I know it says here 1 to 1.5 milligrams per kilogram per day. The new guidelines state 1 milligram per kilogram to the biggest dose of 70 milligrams a day, and you taper that off so quickly over 6 weeks. The thing is, the reason why we would treat is head injuries, other causes. Below 30, we treat with 1 milligram prednisolone, 1 milligram per kilogram, up to 70 milligrams, and taper off. We can also give them IVIG. IVIG works very nicely and can help with the, improving the platelet count. Of course, we treat with any hemorrhage or life-threatening disease. We give platelet transfusions, we give IVIG, and the IVIG is 1 gram per kilogram, ideal body weight, not 1 gram per kilogram per body weight, ideal body weight, and it is 1 dose, unless within 3 days the platelets haven't gone up, then we can give them a second dose. We also can give them methylpred, and in emergency, you basically throw everything at the patient, everything. But everything is individualized to the patient. When we're doing ITP in adults, we start off, as I said, with corticosteroids, their treatments, and IVIG. And over there in the second line is immunosuppressant, corticosteroid sparing agents, which is dapsone, monoclonal clonal antibodies, which is rituximab, a splenectomy. We do not splenectomize, and the new guidelines state you've got to wait at least 18 months to splenectomize. And from a TPO agonist, and we give quite frequently. During the pandemic, we were very lucky to get TPOs up front. If we were tapering the prednisolone down and the platelets were dropping, we could start a TPO agonist, because TPO agonists are only allowed to be started in chronic ITP. But we'll go through those in the next, we'll go through the treatments in the next session. First line, if we fail any of these treatments, then we can have combination of therapies, which is rituximab with dexamethasone, with combinations. So we would go TPO, rituximab, dexamethasone, and immunosuppression. But we don't usually like to do all of that at the same time, because you can actually push the platelets all over the place above 500. And in emergency, yes, I have to say, we did a splenectomy after 2 months because nothing worked. And yes, I hate the idea that we did a splenectomy, and luckily it worked. And we do a combination of all the treatments, and we use platelet transfusions and IVIG. The prognosis for ITP varies from patient to patient. As I've always said to everybody, 80% of children will recover spontaneously, but chronic ITP is usually more frequent in adults. If the patients are responsive to therapy, mortality is similar to the general population. But if they don't respond, they are at a higher risk. But with the new treatments that are coming on, we can generally throw something else at them and try and stabilize them with using combinations of therapies and treatments. You must understand that patients with platelets lower than 30 are more likely to have a serious bleeding event.